Hello, I'm Andrew Menzies-Gow and I'm going to be taking you through this short video on asthma diagnosis. Thank you for taking the time to watch the video. Now, asthma is the most common chronic respiratory condition in the world, with it affecting over 340 million people. It's a chronic condition with a primary driver being airways inflammation, and you can see from the cartoon, you can see the asthmatic bronchiole compared with a normal bronchiole, often with allergic and eosinophilic inflammation, and also what we call airways hyperactivity. So the airway smooth muscle around the bronchi spasms, causing symptoms of wheeze and bronchial hyperresponsiveness. And in combination, we get the classic symptoms of cough, wheeze, chest tightness, and shortness of breath, which we recognize as being very commonly seen in people with asthma. Asthma can be very difficult to diagnose for several reasons, but often it's the symptoms are non-specific, such as breathlessness or chest tightness. Wheeze is more classical, but if you ask someone what they mean by wheeze, often people mean different things by it. I think frequently the problem for me is that it's a variable condition, often worse in the middle of the night, often better in the afternoon. So we might see someone in the afternoon who was very symptomatic at 4 a.m. We're seeing them now with no symptoms at that time, so the physical examination may be normal. So I think really we know that symptoms vary over time and in intensity, together with variable airflow obstruction. So it's very important to do objective tests to either confirm or deny the presence of asthma. And you can see on the left here the classic symptoms and signs, and on the right the classic triggers. But unfortunately on their own, they're not really good enough to tell us whether someone's got asthma or not. And we know because of that all the guidelines, whether we look at the NICE guidelines, the BTS sign guidelines, or the global guidelines GINA, they all suggest that we perform objective tests. They also say that there's not a single test we can do to diagnose asthma. So we have to think about diagnostic algorithms. Really important we do this because often asthma is a lifelong diagnosis when it's been made. And we know that to a certain extent there's an overdiagnosis of asthma in people with a label of asthma. If we do objective tests, up to a third of people with a label of asthma don't actually have evidence of airways obstruction or airways hyperactivity. And equally importantly, there are many people who are breathless with an undifferentiated cause, and they may well have asthma. So very important to get the diagnosis right first time to guide treatment effectively and allow us to improve morbidity and prevent mortality. And if we look at the objective tests, there are multiple different tests to look at. And I think the first important thing to do is take a very clear history, physical examination. That will increase our suspicion for asthma, or think about other things that could be causing it. Also very important that we think about not only airways obstruction in terms of peak flow and spirometry you can see on here, but also airways inflammation, and wherever possible measure exhaled nitric oxide levels. You can see all the cutoffs we've got here, starting with obstructive spirometry and then measuring nitric oxide levels. And I think really what you do depends on what's immediately available and how unwell a person is, but essentially, whenever you do this, you may not be able to do it on day one, as well as booking in for a spirometry with reversibility, nitric oxide levels. Provide the person in front of you with a peak flow meter and a peak flow diary so they can start to record their peak flows, and we can look for diurnal variability over sort of a 2 to 4 week period. So you can see right at the bottom, we've got direct bronchial challenging with histamine or methacholine. Now clearly that's very much a secondary care test, which is done really when we're struggling to make the diagnosis and not something that we'd be looking to occur in primary care or indeed routinely in secondary care at the moment. So in terms of initial treatment, again, very important. I've already said that it's a difficult diagnosis to make. We should be doing objective testing, but if we see someone who's acutely unwell and symptomatic in front of us, we shouldn't delay treatment to allow that testing to occur, because with all the will in the world, it may not be able to happen on that day, and we need to treat asthma. Now we know that asthma is primarily an inflammatory disease of the airways, so initial treatment should be with inhaled corticosteroids that target the airways inflammation. If the patient is highly symptomatic at risk of an exacerbation, we can think about a salbutamol inhaler as a bronchodilator, but we shouldn't be prescribing salbutamol inhalers alone because of the inherent risks associated with that. And indeed, some people may need oral corticosteroids at their first assessment if they're acutely unwell, or even referral to the emergency department. But we should base that on our clinical severity and at least a measurement of peak flow. And I think really importantly, once we can get the objective test done, we get the objective test done so we can review whether or not we've got the diagnosis right. It's very important not to leave patients on inhaled therapy for a prolonged period of time without a confirmed diagnosis. And in terms of a plug for a couple of the other videos we've got within this session, video 4 discusses device choice. It's really important that we give patients a device that they can use. We might want to use a spacer if we're providing them with a metered-dose inhaler. And whatever we do, really, we must make sure that we're treating the airways inflammation with an inhaled corticosteroid. And then in terms of coding, I think it's very important to have a two-step approach here. So we start with a code of suspected asthma, because on that first presentation, we just won't know. This is a lifelong condition. We need to do those objective tests. So we start with a code of suspected asthma, so we've got that cohort easily identifiable. And then I think as we move on from there, there's some key questions that we need to be able to answer. Where will our patients get their objective tests? Who will then follow up with those results? What do we do to try and get hold of people if they don't come for their tests? And then once we've done those diagnostic tests, are we confident in the diagnosis, or does that diagnosis remain unclear? And I think at follow-up, if there's been a combination of objective tests and or you're satisfied from the treatment trial with inhaled corticosteroids, with the peak flow improving, symptoms improving, we can move away from a code of suspected asthma to a code of asthma. Again, I've stressed already a couple of times, this is potentially a lifelong diagnosis. It may take a while to be certain, and even in my position in tertiary care where I have a lot of tests available to me, it may take several months before I'm confident that someone has a diagnosis of asthma or not. And I will take that time because, as I've said, that's a potentially lifelong diagnosis, and we want to make sure it's as secure as it can be. So to make that accurate diagnosis, we want a combination of those confirmatory tests, normally spirometry, peak flow measurements, exhaled nitric oxide measurements. We want to demonstrate that a trial of treatment with inhaled corticosteroids improves symptoms over 6 to 8 weeks. Important to remember, inhaled steroids don't work immediately. They have an anti-inflammatory effect that builds up over time. And if the diagnosis is unclear, then it's very, very reasonable to think about referral to either an integrated care physician or a secondary care respiratory physician, because we want to be confident we've made the right diagnosis. In people with severe asthma that are referred to specialist centres, up somewhere between 10 and 20% have a different diagnosis driving symptoms. So it's very important at the beginning of the patient journey to make sure we've got that diagnosis right. So in terms of the quality improvement projects in this section, it really helps you think about whether there's a potential to improve your process for making that initial diagnosis and moving from coding of suspected to severe asthma. And this includes, the QI projects include coding, organising confirmatory tests, commencing initial treatment and follow-up, and they also help you identify if there's a cohort of patients who've been attending with possible respiratory diagnosis in the past and been prescribed a salbutamol reliever inhaler only, and then who need a confirmatory follow-up to diagnose whether or not they've got asthma or something else that's driving their respiratory symptoms. Thank you very much for your attention.